Hello, everybody. Welcome to another edition of AFR's EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue, and today I am joined by Lieutenant Calvin Lang and also Lieutenant Chuck Demas. Thank you, brothers, for joining us today to talk about a very interesting case where we had essentially a delirious patient with some self-inflicted stab wounds. Now, typically we open these up by talking about the dispatch, how you prepare for that type of call, that sort of thing. But this situation was unique in that you weren't dispatched to the call. You were actually clearing a call and then stumbled upon this. So I'll start with you, LT. Tell me about where you guys were, what happened when you cleared that call, and what you found.
We had just cleared a chest pain call. We were heading back to the station. The rescue was in front of us a little bit as they drove down Wyoming. They came past a person in the street. They continued on, seeing that something was strange, but there was a person in the street. We saw it and saw there was two other people entering the street in pursuit of that person. Another vehicle had stopped. I told my driver to stop and let's just kind of see what was happening. The original person, dressed all in black, long sleeves, walked away from the two people that were pursuing and punched herself several times. After she pulled her hand away, I saw that it was covered in blood. There was a large knife. She'd punched herself several times in the abdomen and stabbed herself several times in the abdomen. So I got on the radio. I started calling for resources, PD, calling for a call to be created. And at that point, the other bystanders that were going after her started chasing her again, and she started running out into other parts of the street. So I got out of the truck and tried to corral them and keep them away from her so that we didn't have a bigger incident. At that same time, the rescue pulled up and blocked the whole other side of the street, so we had the entire street of Wyoming blocked. At that point, we looked up and saw PD coming down and trying to get control of the situation that way.
Unbelievable. So, Chuck, you guys, APD was there. Obviously, scene safety is our first priority, so we're not going to approach that patient until the patient has been secured by law enforcement. Thankfully, APD had a great response time. They were there with us. They were able to secure the weapon and secure the patient. So you made initial contact. What did you find when you did your initial assessment?
Well, actually, the pumper guys made contact with her first. I actually, just because we knew she'd be combative of some sort, I told Jonah to grab the gurney and meet the pumper guys to get her on the gurney. While he was doing that, I was like, I'm going to grab the narcs. So I went in the back of the truck, grabbed my narcs, and by the time I was walking out to the truck and I was actually walking back towards the patient, I was actually drawing up my narcs as they were getting her on the gurney. As we were getting her strapped in, I was actually able to give her a Versed as we were strapping her in. And she was wordlessly just screaming at us, just got her all growling at the time. When guys made contact with her. But we got her on the gurney and got her loaded back in the truck within 30, 40 seconds of making contact with this lady and had drugs on board and getting her loaded up.
So obviously initial altered mental status, still really combative. After you administered the drugs, was it able to calm her down? Did you do a good assessment?
Yeah, actually. So once we got her on the gurney and stuff like that, just because we saw her stab herself and she did serious wounds. I mean, it was a 4-inch knife. Had a good look at the knife, just that way we could tell the hospital staff. She'd slit her wrists, slit her throat. She actually stabbed herself on both sides of the neck, and about 9 stab wounds in the abdomen. But so what we did, once we got her on the gurney in the back of the truck, we got out our trauma shears and exposed her because we needed to find out where all her wounds were. About 3 minutes into the transport, the Versed started to work, and I was actually able to have a conversation and actually get some history from her and things like that. She admitted to meth use and was actually kind of A&O times 4 and was able to answer some decent questions for us. One of the things I was worried when she stabbed herself in the neck was her airway, compromised and bleeding in the airway and stuff, and thankfully her airway was intact, so I really didn't have to do much there. We were kind of fortunate that her wounds made it kind of easy.
Yeah. Yeah, those penetrating neck injuries, super dangerous. Obviously, we're looking for like the potential for that expanding hematoma and having that airway compromise. Thankfully, we didn't have that, but you guys were prepared to be able to handle it if that was the case. Talk to us a little bit about the sedation prior to providing treatment. I think we've had multiple cases now where it's either self-inflicted wounds or maybe not self-inflicted wounds where they need to be treated, but they are too agitated to be able to safely respond. Talk through us why it's important to be able to sedate that patient first in terms of your safety as also the patient's safety.
Oh, plain and simply, somebody even like this lady who's maybe 110, 120 pounds, when they are in an altered mental state, they have a lot of strength, and you can hurt guys can get struck, they can hurt their backs in trying to hold the patient down or, hold their body weight up and that kind of thing. So it's a matter of just keeping us safe.
In this case, I mean, she was covered in blood and she was spurting from different locations. So as we were having to wrestle with her and get her on the bed and fight with her, it was getting messy.
So we said multiple to the neck. Was there one to the? How many to the neck? How many to the abdomen?
She saw one and then another one. So there was one on each side of her neck that she plunged it in. The abdomen, Chuck counted 9.
Nine stab wounds to the abdomen, but on the wrists and on her neck, she actually she had slitting wounds that actually, so a couple of them were suturable, for sure. I mean, she did some serious harm to herself.
Anything to the chest?
Nothing in the chest area.
Super experienced paramedic. One of my favorite go-tos to ask questions is as far as pathophys, and needle decompression comes up a lot, right, when you're dealing with just mechanism. And I think historically we've focused predominantly on mechanism to say this person is going to need a needle decompression. Now, obviously, it sounds like the patient was otherwise stable during transport. But from your experiences, can you talk through us your decision-making process when it comes to needle decompression? When do you initiate that level of treatment?
I generally base it on the patient's work of effort in breathing. If they're showing me signs of distress, things like in the books where it's talking tracheal deviation and JVD, all that, that's actually late signs, and you're way behind the ball. But if you're listening to lung sounds and reassessing lung sounds, looking for the sucking chest wounds, that type of thing, it really depends on the way your patient presents. What are their SATs looking like? But look at your patient. Look at their skin color. Look at their work of effort and their breathing. But all the numbers are great, but treat your patient, not the numbers.
Right, absolutely. That everybody wrote in, was it just Station 20 that wrote in on the transport?
Just Station 20. We took, I believe, actually it was just me in the back.
You were in the back.
Did I take a pipeman? I can't remember specifically.
Yeah, we had Jason Chavez piping.
That's right, Jason
and
Chavez.
Daniel O'Brien hopped in, and then I got in to notate, but once we started wrestling with her, I put gloves on, and I didn't end up notating anything.
Was it 5 milligrams of Versed, or what did you do?
Just 5 milligrams is what we gave.
And then she was able to calm her down like you talked about.
Yes, and then she was actually able to answer. Like before that, she was just screaming and yelling and being completely combative, and I was actually surprised to be able to have a conversation with her. It was actually a pleasant surprise.
Turnover at the hospital. Talk to us a little bit about that. When you guys arrived, I'm assuming IVs established was really the only thing you had time to do at that point?
It was actually really quick transport. I think I missed one and Jason missed one. Unfortunately, we didn't actually. So we had 2 attempts. We just didn't get an IV. It was surprisingly for a young lady, she didn't have great veins.
No vascular access. Yeah, it happens.
And yeah, we're pretty good with our IV skills, but at the same time, I'm surprised. I missed.
Hey, there's a lot going on in that call, so no judgment here at all. So chemical restraint, did it require physical restraints at all?
We started with physical restraints because, like I said, I had Jonah grab the gurney and met the pumper guys who were already out, and the guys physically restrained her and put her on the gurney, and then we loaded her on the gurney, and as we were strapping her in, literally in the middle of the street, I was able to give her the shot in the arm in the street. So literally physically and chemically restrained before we even had her in the back of the truck.
Awesome. Transfer over to the hospital. Any issues?
Smooth as silk. They actually, within about 5 minutes, they were rolling her off into the OR. I mean, they did some basic assessments and saw the wounds, and then they needed to get her to do some exploratory surgery.
Yeah, it was bright lights and cold steel at that point. Fantastic job. The dynamic scene for sure, a lot of components of that. The scene safety, I think, was paramount. You guys did a great job of not just rushing into a scene, waiting for that to be somewhat secured, and then being Johnny on the spot to get her on the gurney, execute the transport. I think it was fantastic. From your perspective, LT, any takeaways? This is a unique case, but if you had another less seasoned officer who encounters this, who's on a big red truck, let's say they're on a BLS unit, what are some key takeaways that you would provide to them?
Blocking the traffic, obviously. Lock out the biggest area you can. Either leave your guys in the truck or use them to secure further parts of the scene, but give that person a lot of space and keep the other bystanders out of the way. You're going to have to be aggressive with that to maintain that scene, but set some type of perimeter around her while you're waiting for help, because at the end of the day, that's really what you need.
Yeah, you can't have the one patient turn into multiple patients by engaging too early without being safe. That's great. And then from the ALS perspective, you've covered a lot of it, but any takeaways that you would provide somebody who's new in that seat on the paramedic side to be able to handle this type of call?
It was so fast, there wasn't really a chance to have a plan of action. But as soon as we got there, like I said, Calvin did a great job of keeping the bystanders and himself, keep everybody on the truck until the scene's secure. And everybody literally did that, of course, except for Calvin, telling the people to back off, having to hop out. But he stayed behind on the other side of the truck. And as far as, have a plan of action, give different people a job. Most of the guys, they're adults, they know the job, but it doesn't hurt to verbalize it, to get a plan of action to make it go a little bit smoother.
Yeah, and I think absolutely the biggest takeaway for me in this case was the sedation prior to initiating treatment, because I think theoretically, even if you had the physical restraints, you wouldn't have been able to provide good care until she actually calmed down.
So. No, she was initially before it started kicking in, she was thrashing around. There's nothing we could literally do other than, like I said, expose to find more wounds.
Great job. Outstanding case. I appreciate you guys taking the time to come and talk to us about it, especially from both perspectives on the big red truck as well as the rescue. We want to encourage more folks on the BLS side, if they have interesting cases, to come in and talk through those. So I appreciate you, Lieutenant Lang, for coming to do that. Lieutenant Demas, as always, if anybody has any interesting cases they want to bring, we have the SharePoint tab. You can make the submission. You can reach out to anybody in the EMS division. If you're not comfortable talking about it on camera, then we can talk about the case on your behalf. But keep those cases coming. I think this is the best way for us to educate other providers on how to handle these unique situations. And until then, we'll see you next time. Thank you.